low to intermediate patient. In that patient, we have now investigation of choice, that is CT angio. And those patients who are fall into moderate to high pretest probability likelihood of coronary disease, then in this patient we can advise a functional imaging testing. And the fourth category is those patients who fall into a very high risk pattern of disease progression. That type of patient, we can go directly for invasive angiography. So some glimpse from our recent ESC guideline for the lifestyle modification. Is all we know, smoking is a very high risk. Smoking, substance abuse, obesity and weight loss, overweight, hyperlipidemia, diabetes, arterial hypertension, and lifestyle and physical activity. They are all uh, uh, causes and precipitating factors of chronic coronary syndrome. So we have to abstain the smoking cessation. We have to give help the patient to assess to abstain the smoking cessation. And for the obese patient and over patient, we have to advise them to keep their BMI around 18.5 to 25. And for the dyslipidemic patient, we will have a target LDL cholesterol is in 55 milligram per deciliter, or we have to achieve the target on the basis of treatment more than 50%. And diabetes patient, we have to advise them to keep his hemoglobin A1C less than 7%. For the hypertension patient, we have to keep his heart blood pressure around 120 to 129. And for the diet, that we have to advise patient the fibrous diet. They follow the Mediterranean diet and limit his alcohol consumption to less than 100 gram per week. And we have to advise for the physical activity around 30 to 60 minutes, moderate activity, or more than 5 days a week, and advise them to work to be and mobilize, not to avoid sedentary lifestyle. Okay, then we have a lifestyle modification, then drug treatment. We have anti-anginal. We have all these groups for the angina, nitrate, calcium channel blocker, beta blocker, potassium channel blocker, and other miscellaneous drugs like this dipyridinol, aspirin, trimetazone, ranolazine, amitriptyline. Okay. This is a possible combination of anti-anginal drugs according to patient's disease pattern, according to patient condition. If we have to achieve the target heart rate, if the patient have any heart rate more than 70, then we have to control his heart rate with the beta blocker, verapamil, diltiazem, verapamil, along with the trimetazone and ranolazine combination. And those patients who are baseline bradycardia, we have to avoid beta blocker, verapamil, diltiazem, and avapritinol. We have to alternate to these drugs. We have to give dihydropyridine, nitrate, trimetazine, ranolazine. And arterial hypertension patient, we have to give all these groups: beta blocker, dihydropyridine, diltiazem, verapamil, nitrate, trimetazone, ranolazine. And hypertension patient, trimetazone, ranolazine, or avapritinol. And airway dysfunction preferred is a beta blocker, along with these trimetazone, avapritinol, ranolazine, nitrate. Heart failure patient, beta blocker, nitrate, ranolazine, and other disease modifying drugs. And for the atrial fibrillation, we have to control heart rate, then in which we can give beta blocker, verapamil, diltiazem. This paragraph derives from the recent ESC 2024 guidelines. That is like a mirror image of previous slides. That also show a different group of anti-anginal drugs, and how we prescribe according to condition of patient. If and some benefit of these drugs, like beta blocker, we can give them an obstructive coronary disease, microvascular dysfunction, arterial hypertension, atrial fibrillation, heart failure, reduced EF, obstructive coronary disease. In obstructive coronary disease, we have to give dihydropyridine, calcium channel blockers, and and diltiazem, obstructive coronary vasospastic angina, or arterial hypertension. And like same trimetazine, we can give in obstructive coronary disease, microvascular dysfunction. Ranitidine, obstructive coronary disease, microvascular dysfunction. And nitrate, we have to avoid in vacuum, and we can give an obstructive coronary artery and vasospastic angina. So this is a new recommendation for controlling the LDL cholesterol. We have to treat the patient to achieve a target LDL less than 1.4 millimole or 55 milligram per deciliter. With the target, we achieve more than 50% reduction in the LDL cholesterol. That's a class 1 recommendation. For patients who are statin intolerance, are their targets are not achieved by easy. Now we have a new drug that's as the bempedoic acid. We can recommend that's a FDA approved and now included in recent ESC guidelines. And for the patient who we cannot achieve the target with a statin, ezetimibe, we can give add-on therapy with bempedoic acid as well. That's class 2 recommendation. This is also a new recommendation. Okay, I have just mentioned one class 1 recommendation for the invasive coronary angiography. I will not go in detail of invasive coronary angiography. That's in those patients with the chronic coronary syndrome with ischemic aortic dysfunction, EF less than 35, and according to their if they are choose for the revascularization or the medical therapy after careful evaluation, preferably by the heart team discussion and is on the basis of his coronary anatomy and correlation between the coronary artery disease and any dysfunction, comorbidity, life expectancy, individual risk to benefit ratio, and patient perspective. Okay, this is a recommendation for the antithrombotic therapy. We give aspirin to lifelong patient to those patients who have a previous MI or who undergo for any coronary revascularization. Alternate to that's a class 1 recommendation. Alternate to aspirin if any contraindication for aspirin. Clopidogrel is a class 1 recommendation. Alternate to aspirin. After cabbage, we can give lifelong aspirin 75 to 100 milligram. And in patient, that's the fourth category, class 1 recommendation. And patient without prior MI solution, but with the evidence of significant absent coronary disease, we also give them a lifelong recommendation of aspirin dose of 75 milligram to 100 milligram. So in those patients who undergo for any intervention or the PCI and who have indication for oral anticoagulation, we have to give aspirin along with the oral anticoagulation. We have to give aspirin and clopidogrel along with the oral anticoagulation in first few months. And after and those patients who have indication of any other for integration, oral integration, we have to select the direct oral integration preference to the vitamin K integration. So those patients who are at higher risk for the bleeding, then we have to we can also see the early cessation of aspirin less than 1 week, followed by a continuation of oral anticoagulation and clopidogrel. That is up to 6 months. After up to 6 months, we have to just give them oral anticoagulation. Okay, this is our day-to-day practice. How we will prescribe a dual antiplatelet to those patients, chronic coronary patients. There are almost three categories. First of all, are those patients who have non-high ischemic risk. We can give them around 1 to 3 months DAPT, then aspirin or clopidogrel around for the lifelong. If patient have a high ischemic risk, then we can give DAPT along with the clopidogrel or newer drugs like ticagrelor, pasugrel, up to 6 months. Then we have to shift that patient to the continue for life for DAPT, that's class 2 recommendation. And